We're taking the medical and dental history. We know what their recent treatment was. If the crown was put on 2 months ago, we need to know that. If it's been 5 years since the patient's had treatment, then that may lead us to potentially less of a specific location for the pain, as opposed to I had a crown on number 30 a month ago, and now I can't chew on number 30. But we need to record the chief complaint. How long has this been going on? What are the symptoms? How long does it last? Where does it start? What makes it start? Is it just very sharp, or is it dull? How long? Does this last for hours, for minutes? When I drink cold, it lingers, it doesn't linger, those types of things. And facial asymmetries. Is there a sinus tract? All of these things. Is there caries? How many restorations do we have? What's the probing? All of these things are pieces of evidence that collectively, when we record them in a grid format in our charting, will slowly build the case that we have the correct tooth. And we need thermal testing, whether that's hot, cold, potentially electric. We need to be able to perform those with confidence and know what those are telling us. So if we test number 29 and they feel the cold and it goes away, we test 31, they feel the cold and it goes away, we put the cold on 30 and they don't feel anything, and their pain is a dull pain that is centered around number 30, that's a bingo. That's number 30. It's a non-vital pulp or a partially necrotic pulp that needs attention. And so we're also going to test percussion, palpation. The value of knowing whether the tooth is percussion sensitive is it tells us whether there's inflammation in the bone, and palpation sensitivity tells us the degree of apical inflammation and how far and wide that inflammation has spread. So sometimes you'll have a tooth that's sensitive to percussion, but not to palpation. Or if you have both, then you know that this is a more long-standing condition. So realistically, we want at least 2 periapicals, maybe a bite wing to see what the restorative status is there decay, and then CBCT when we need it. We're always going to derive for the patient prior to treatment a pulpal and a periapical diagnosis. And when we're in doubt, we don't know, we're not sure for whatever reason, you should refer the case and or observe the patient and reevaluate them. We have basically a number of pulpal diagnoses, and they range from normal to reversible pulpitis to symptomatic irreversible, asymptomatic irreversible, a necrotic pulp, a previously completed treatment, and then a previously initiated treatment. Those are the pulpal diagnoses. Let's talk about the apical, the periapical diagnosis. We can have normal apical tissues, symptomatic apical periodontitis. It can be asymptomatic, chronic apical abscess, or acute apical abscess.